Morning, everybody. Hopefully, I think we've let everybody in. Welcome to the market briefing from Brisbane North PHN around commissioning of a multidisciplinary team to support diabetes management. Before we begin, I'll just introduce myself. My name's Rachel Foreman, and I am the Executive Manager for Health Systems Improvement here at the PHN. I'll just hand over to Amy to introduce herself as well.
Thanks, Rachel. My name's Amy Hood. I'm the development team there, and I undertook some of the stations as
Thanks, Amy. And just to note, we've got a couple of PHN staff who are also sitting in who won't be speaking this morning. So welcome. Before we begin the formality part of the session, I'd just like to acknowledge the traditional owners of the lands that we're all meeting on today. I am on the lands of the Yuggera and Turrbal people in Meanjin, but I'd like to respectfully acknowledge the lands that you're all gathered on, as well as the other traditional custodians in our region, which is the Gubbi Gubbi people of Caboolture and Bribie Island, the Waka Waka people of Kilcoy, and the Ningi Ningi people of Redcliffe. I'd like to pay my respects to elders past, present and future, for they hold the memories, the traditions, the cultures and the hopes of Aboriginal and Torres Strait Islander Australia. So welcome. We just got a little bit of housekeeping just at the beginning, just to set the scene. So this session is scheduled to run for a maximum of 45 minutes. There are opportunities at the end for questions and answers, but if along the way you think of some questions, please post them in the chat function of Teams. You may have noticed at the beginning, it did pop up saying that this session was being recorded. That is both to allow yourselves, if you need to view a copy later on, but also for people who are unable to attend this morning. Amy informs me they will be posted on the My Voice platform where the other documentations are stored as well. And if you haven't already done so, please mute your microphone until we get to the Q&A session, and ideally cameras off, but it's, we haven't got a big group. Next slide. Thanks, Amy. So an overview of the session this morning, we'll just give a little bit of an overview of Brisbane North PHN in case some of you are less familiar with what we do and who we are. A bit of a background to the project. We will then talk a bit more about the details required around commissioning a multidisciplinary team to support diabetes, and then the application process and the milestones and timeframes that we're expecting, which are also in the request for proposal. Next slide, please. So Brisbane North PHN, or Primary Health Network, is one of 31 PHNs across the country and one of 7 PHNs in Queensland. You'll see on the map that's the region that we cover, and we support clinicians and communities in north of the river, in the Moreton Bay Regional Council, parts of Somerset Regional Council, and you'll see right over there on the right of the map, we also support Norfolk Island, which has been 2 years, I think now, since that transitioned to Queensland. We cover a region of just over 4,000 square kilometres, and in the most recent population data, we've actually got a population of over 1.1 million people now. The objectives of PHNs are to increase the efficiency and effectiveness of medical services for patients, and particularly those people who are at high risk of poor health outcomes, and to improve the coordination of care to ensure that patients receive the right care in the right place at the right time. Next slide. Thanks, Amy. So I'll hand over to Amy now, who's going to take you through the project specifics.
Thanks, Rach. So in terms of why this project came about, so for a bit of background, as part of the Building a Stronger Medicare package in their 2024 budget, PHNs were identified as best placed to commission a multi-care team, which is known as MDT throughout all documentation. And these MDTs are to support solo or small general practices or Aboriginal community health services that are too small to engage their own MD through other streams. So the PHN reviewed their region and identified that diabetes management via an MD necessary, and further exploration also highlighted that Strathpine SA advantaged areas So as you can see on the screen there, 57%, so rather 57% of the population is managed, and that's compared in the PHN region. And as we know, people living in disadvantaged twice as hospitalised.
Sorry, Amy, for me, your sound is breaking up a little bit. So just checking if that's the case for you too, Alison. Just nod. Yes. Can you just fix your microphone a little bit, Amy?
Hopefully this is better. Okay, so evidence suggests that access to an MDT model of care whereby different health professionals work together, so GPs, practice nurses, diabetes educators, to name a few, who work closely together to manage diabetes care is highly effective. So an MDT has the potential to enhance patient education, increase patient satisfaction, support patient self-management, improve preventative care, reduce healthcare costs, and result in improved patient outcomes. And that's in comparison to solo practitioner care. And we also know that it results in the reallocation of tasks among team members, which allows GPs more time for other patient care activities. So in terms of the project purpose, the PHN will be commissioning an Allied Health Multidisciplinary Team to provide additional support to initial neighbourhood of 2 to 3 small general practices within the Strathpine SA3 region. And when we say initial, there is scope to actually increase the amount of participating practices, but in the first instance, we're going to be working with 2 to 3. And then that MDT will support those practices with the management of patients with prediabetes and diabetes. So when we refer to prediabetes and diabetes throughout the documentation, that's type 1, type 2, and gestational diabetes. And that service is to target people that cannot afford fee paying or co-payment for MDT services and team care arrangements. So some general information about this commissioning opportunity. The funding is to begin in approximately March and end the 30th of June 2027. So the locations for the service is within that Strathpine SA3 region, which encompasses the suburbs of Bray Park, Brendale, Launton, Petrie, and Strathpine. And we have put throughout the documentation that co-location in the 2 to 3 small general practices within that area will be assessed based on the availability of general practice consulting rooms. So in terms of how that would look, you can see that as once we've contracted a successful provider, that would be phase 2 to this piece of work. So in terms of the contracting model, the PHN's preference is to engage either a single organisation to deliver this service or a consortium with a lead agency. And the service components that we've specified is an allied health professional that is either a credentialed diabetes educator, a dietitian, exercise physiologist, and podiatrist. But that's not limited to the service. We are accepting other allied health professionals. And as you can see, the benefits, once benefits are realised, the expansion could also include the recruitment of additional allied health professionals, such as a pharmacist, Aboriginal and Torres Strait Islander health worker, and a social worker. So the target group for this service is, as mentioned, patients with a diagnosis of prediabetes and diabetes, and the priority populations for the service will include people from culturally and linguistically diverse communities, people with a disability, people who identify as LGBTQIA+, and First Nations peoples. And the PHN has resources and training available to support these priority populations, which I'll further discuss later on in the slides. So back in November of 2024, the PHN met with the Strathpine SA3 general practices and heard from them some of the model specifications that must be encompassed as part of this service. So the provision of pre-diabetes and diabetes management services at no or minimal cost to patients. A diverse local workforce of allied health professionals was required. Availability of consulting rooms within that Strathpine SA3 region or outreach services in local community health centres, and that ability to co-locate with general practices where required. And I will specify that not all of the practices you'll be working with will have availability of consulting rooms. So that's why we've specified that it may not be necessary, but we do expect providers to consider that as part of the application. We also require the provider to address solutions to transportation challenges. So we're suggesting utilising a hybrid approach of in-person and telehealth consultations. So the integration of case conferencing, provision of evidence-based, group-based patient education sessions. So you're probably familiar with Diabetes Australia's Desmond and or SMARTS programs. And another program that the PHN is involved with closely is Diabetes Australia's My Health for Life. And we've specified these programs because we are trying to prevent any duplication of services with this commissioning piece. Another requirement for providers is that they incorporate meetings, training and education initiatives for the 2 to 3 general practices, and that's done to facilitate the service integration and provide the practices with an understanding of the proposed allied health professionals role scope. And then finally, we expect that the model that you're proposing has a focus on sustainability that extends beyond the conclusion of the pilot program, just so that no patients are displaced from the implementation of this service. And finally, the model specifications also incorporate that further development in collaboration with an initial 2 to 3 general practices will be required. So that will look like establishing methods of operation, including an agreement for the secure transfer of patient information. In our region, our practices generally utilise best practice as a clinical information system, but we also have some that have medical director. I've also linked further in this presentation some information on secure messaging, as I know that not all providers are familiar with this term and what that means. And also we're expecting the provider to meet with the general practices to determine a frequency of meetings throughout the course of this pilot until its end in 2027. And again, the provider will need to assess the need for co-location and the availability of general practice consulting rooms and clarify roles and responsibilities to achieve the intended outcomes of the pilot. So milestones related with this commissioning piece, you're all aware that this opportunity was released on the 20th of December 2024, and today is a market briefing, which is the 17th of January 2025. This opportunity will close midnight the 31st of January 2025, and proposals are to be submitted via the My Voice platform. So in other words, any applications we receive from the 1st of February will not be accepted into the panel review. So panel review and moderation will occur the week of the 17th of February. And our panel will consist of a consumer with a living experience of diabetes type 1, and a local general practitioner, and our PHN executive, which is Rachel, and Alison Leach, who is our primary care manager. We anticipate that interviews will be held the week of the 24th of February, so we kindly ask that you consider this as part of your application. And we aim to have negotiations and contract complete the week of the 3rd of March in anticipation for service commencement sometime in March. And when we specify service commencement, that would be typically via a soft launch. We wouldn't do any promotion, just so that the provider can get things going and work out any streamline to the processes with the 2 to 3 general practices. So in the online application form, we're expecting that the following criteria is sufficiently and adequately addressed. So that's the methodology and approach. So we expect that providers are putting in a methodology and approach that will be used to deliver the pilot, including examples of similar projects completed with a focus on meeting the model specifications and how they aim to collaborate with the 2 to 3 general practices. And of course, all proposals need a project schedule, so we will be expecting some form of timeline. It could be a Gantt chart, including key steps and milestones in line with the project timelines supplied in Part B. So again, that's expecting providers to be able to establish services within a short time frame with a target commencement date set for March 2025. And then with your budget, we expect an itemised budget to the best of your abilities in alignment with the available funding that we've going to present in another slide shortly. If you're proposing certain allied health professionals to participate in this pilot, please provide a professional summary of each of those personnel, and a brief CV of no longer than 2 pages will be necessary as part of your application. Then in terms of contact person, this is a really important step. Please provide details of somebody who will be receiving the advice of the result of their request for proposal. So the application form asks for a name, position, telephone number, postal address, and email. So this will be the person that we contact about the interviews, potential interviews as well. So expect some phone call from the PHN. And then finally, the due diligence is always a requirement of our commission services, so including your public liability insurance and a copy of the PHN's information security assessment form, which is all available on the My Voice platform if you haven't seen it already. So what will the assessment panel be reviewing your applications based on? It's the assessment criteria, and we've got 7 key criteria as part of this request for proposal. So the first one being sector knowledge. We're asking respondents to display an understanding of the available services, emerging issues, and desired health outcomes for patients with pre-diabetes and diabetes. And again, focusing on supporting individuals with financial distress and those from areas of disadvantage. So that's Strathpine SA3 area. That's weighted at 5%. Then we also have demonstrated experience as a criteria. So we're expecting proposals to be from a high-performing quality organisation with expertise delivering evidence-based MDT focused on pre-diabetes and diabetes, and somebody who can work within a network of healthcare providers. So that's weighted at 15%. And the highest weighted criteria is the service delivery model. As you can imagine, that's an important component that we're expecting you to provide us information on how that should be achieved. So we're asking that your service delivery model include the local general practices model specifications, and any other ideas that you can implement throughout the course of the pilot. And that's weighted at 30%. And then we have financial sustainability. So we're asking you to incorporate in your itemised budget any costs that also link in with existing services to reduce duplication of the existing programs in that Strathpine SA3 region. We've also got governance, which as part of clinical service delivery is necessary, and we're asking that you propose a governance structure which will ensure the services are delivered as intended, and that's weighted at 15%. And then evaluation and measures of success is a requirement of all our commissioned services. We'll negotiate the terms of sharing de-identified data with the PHM, but we're asking that as part of your proposal, you demonstrate a clear evaluation mechanism to collect and monitor service data. So that's your satisfaction surveys and the ability to synthesize trends to identify continuous quality improvement activities. And I just thought I'd also mention too that the evaluation that you propose must be able to incorporate the potential of a patient-reported outcome measure recommended by the Department of Health and Aged Care. So that criteria is weighted at 15%. And finally, because this is a key component of this model, collaboration has been included in the criteria. So we are asking that respondents demonstrate plans to collaborate with the 2 to 3 general practices, ensuring cohesion across the network. So that's scored at or weighted at 5%. And then with all of our commissioning pieces, we have conditions for applications. This does come up when you go to submit your applications, but I will read that out for the purposes of this presentation, that incomplete or ineligible applications will not be processed or considered. So that includes any applications received after the closing date of midnight 31st of January. So anything received on the 1st will not be considered. This invitation for proposal does not create a legal or binding commitment, arrangement or understanding between the PHN and the recipient of the invitation, and any commitment will be the subject of further negotiation and documentation. And this invitation for proposal may be reviewed and amended at any time. And please do not include any expenses and costs associated with preparing your application in your budget. The applicant has to unconditionally agree to bear those expenses as part of this process. And then finally, we have for the budget a total of $1.4 million plus GST provided in accordance with the following table. So for this financial year, we have $414,000. And then the subsequent year, we have $490,500. And the final year of service would be $500,061 available. And this amount may change throughout the course, but what we do as PHN is we meet with our service providers, preferably quarterly. In the initial stages of the service, it's quite monthly, and we can discuss the budget because, as you can imagine, we've only got a few more months left of this financial year, so we can discuss how that will be funded and if there's any rollover and things like that. So we'll just open up the floor to any questions. I did want to flag that as part of the frequently asked questions document on the My Voice platform, we have already received through some questions, which I've just posted on the screen there. But to summarise, the PHN has completed their joint regional needs assessment, which is done every 3 years, and it's available via the following link. We've also provided further information about secure messaging through the Australian Digital Health Agency's resource, which is also linked. And we also offer training and resources to providers to support priority populations in a culturally sensitive manner, which is available until December 2025 and linked on the screen as well. So I'll just open up the floor to any questions. We've got none in the chat. Brady, go ahead.
Hi, Amy. Hi, everybody. Thanks for the presentation. Couple of questions. First one, communicating to additional practices. So there's obviously a focus for those 2 to 3 practices initially. However, in those communities, there are a considerable number of GP practices. Is the project solely targeting those 2 to 3, or is the successful tenderer encouraged to be able to communicate with all practices?
Rachel, are you okay if I address this question? So Brady, the 2 to 3 general practices that we've identified are actually not claiming the workforce incentive payment practice stream. So at this stage, it would be working with those 2 to 3 general practices. And then if there are any other practices within that region that are identified or come forward as no longer claiming that workforce incentive payment, they would be invited to participate. So it is discreetly for a particular set of general practices, and we've got approximately 14 in that region. But at this stage, it would be the 2 to 3, and depending on patient throughput, we could also expand that out. But in the first initial stages, it would be just 2 to 3 general practices, and we'll work with those 2 to 3 general practices to develop a memorandum of understanding that'll be signed to ensure that the allied health provider is supported as part of this commissioning piece.
And then
sorry, Brady, can I just add before you go to your next question? Because the grant guidelines that the PHN received from the department for this pilot piece of work does specify that, as per the request for proposal, that it's really for those small or solo general practices that aren't eligible or aren't claiming the Workforce Incentive Program practice stream. And we recognise totally that there is a much broader need for around diabetes multidisciplinary team care than those small practices. And I guess the filter, Amy has consulted with all of those 14, and because they are small or solo, not all of them have the capacity to engage with the project at this point in time, or they may be choosing to wait and watch and see what happens as such. So I guess we've said it's an initial 2 to 3, and then it may scale, but it's not going to scale to the massive practices in that region because that's not in the scope of the guidelines, if that makes sense.
Yeah, it certainly is. Yeah, thank you for answering that. And my only other question was in relation to the financial year payments. If anticipation of expected service delivery is to commence March, that's March, April, May, June, 4 months, and the amount of funding prioritised for the 24 to 25 financial year is 414,000. That's a very tight amount of time to sufficiently expend that funding. Just interested on comments on that, of whether there's potential for some of that funding to go into that second financial year to be utilised as the project really flourishes and comes into its own.
Rachel, did you want to answer this one?
Yeah, I will. Thanks, Brady. Yeah, and yes, and Amy did allude to this a little bit, but just to be very clear, yes, there is that ability to work with a successful service provider to look at rollover requests and to approve that in a variation through to the next financial year, and similarly the following financial year, etc. The department, and even possibly the following financial year, actually, because the department has recently said, due to the delay in funding coming to the PHNs, there's the ability to go into that 4th year. But we had already put our documentation out to market. And so again, we would work with the successful provider to look at what year-on-year rollover looks like based on service demand.
Thanks, Rachel. Hope, you had a question.
Yes. Hi, Amy. Hi, Rachel. Thanks for the opportunity today. My question was just around the administration to do with appointment bookings, and whether you foresee that to form part of this proposal, or whether there's been any discussion about the GP clinics themselves taking on some of that administration, noting now that, you know, the successful applicant might not actually be co-located with that general practice. Was just interested on your thoughts on that.
It's a good question, Hope, and I guess this is where that phase 2 component will come in. The 2 to 3 general practices that we've identified all have different staffing structures. Some have practice nurses, some don't. So that's something that would be worked out as that next phase, how the patients are then going to be booked in, or if they're going to be referred. And then there's another follow-up from the allied health provider, but we'd be open to your suggestions as part of the proposal as well. Rachel, did you have any other thoughts to add to that?
No, thanks, Amy.
Thank you.
Great, thanks.
I'll give everyone a minute more if there's any other questions that come through. Alrighty, so in terms of next steps, we're asking providers to submit their request for proposal documentation through My Voice by midnight Friday the 31st of January 2025. And if you've had a look at that application form, it's got all of the mandatory fields. So we're asking that you include a contact person, proposal documentation, the key personnel who will be involved in the project, PHN information security assessment, and a public liability insurance proof. And therefore, we also ask that Providers also be prepared for potential interviews the week of the 24th of February 2025, and a date will be shared once that is known. So if we don't have any further questions, we'll adjourn this meeting now, and this will be posted via the My Voice page for you to refer to. And please review the page for the frequently asked questions documentation that is updated every Friday by 4 p.m. until this opportunity closes on the 31st of January. So we look forward to receiving your applications, and if there's any other questions, please don't hesitate to reach out to myself. So we'll close the meeting now. Thank you.
Thank you.
Thank
Bye,
you.
everybody.
Thanks, everybody.